The beginning of life is the focus of Part 4 of the Ethical and Religious Directives. This section provides guidance about many of the issues at the beginning of life, such as contraception, sterilization, abortion, various reproductive procedures, as well as genetic counseling and prenatal diagnosis. Some people find Part 4 challenging because of what it does not permit. In light of that, I think it's important to read the introduction carefully to better understand why the Church does not allow certain procedures. It's also important to note what is permitted. Let's hear from several individuals about Part 4 of the directives.
The starting point of deciding on treating patients in any way with the new or old technologies is anchored in the respect for the individual, dignity of the individual, and respect for their life, whether it's the mother or whether it's the unborn child.
I'm often faced with what do the ERDs say and what don't they say. For example, there are questions that come up not infrequently about, I'm doing a repeat cesarean section on this patient, she wants a tubal ligation, and the ERDs are pretty clear, no, that's not something that we can do at a Catholic hospital. However, there are other issues that arise, such as patients who have critical illness and are pregnant, and can we actually treat this patient when it might have an impact on the fetus? And the ERDs are pretty clear that yes, you can treat the patient and treat them appropriately medically.
In the care provided to women and their children during and after pregnancy, Catholic Healthcare Ministry witnesses to the sanctity of life from conception to natural death. Part 4 of the Ethical and Religious Directives addresses issues in care for the beginning of life.
The ERDs pertain to the values and the mission of physicians, primarily in terms of the sanctity and the reverence for life. They also impact the role of physicians, sometimes by having them have to think a little bit differently.
Because this part of the directives is often so difficult for people to understand, I think it's clearest when we go back to the two basic teachings of the Church that undergird this entire part and from which all these directives flow. So we see that the first basic teaching is respect for the dignity of the person. And we see that throughout the directives. I think it's key in this section as well.
With the dramatic changes which are always occurring within medicine, and specifically in the area of reproductive medicine, there's always the capacity, as outlined by the ethical and religious directives, for both the institution and the provider to inform their own consciousness as to what is appropriate application of new technologies.
The directives are rooted in the Church's deep respect for the family, for marriage, and for the love that unites the married couple and brings forth new life.
The second is the teaching of the Church with regard to marriage as a sacrament and the place that the marital act has within the marriage. The two purposes of the marital act are both the unitive and the procreative. And what's essential there is that those two always be together, cannot be separated, one cannot be suppressed to the benefit of the other. Respect for the dignity of the person and the sanctity of life underlie all of the directives. In Part 4, we see that belief combined with the role of marriage and the meanings of the marital act, and it really does give us good guidance.
Reverence for the dignity of each human person is the basis for the Church's teaching about abortion and sterilization.
Clearly, abortion is not permitted, and that's usually the easiest part of this section to grasp.
Sometimes serious problems arise during pregnancy in which clinical evidence indicates that the fetus will not survive. These are very difficult and painful situations for the mother and the family.
And we have a number of patients that have specifically come to us because they know that we'll continue the pregnancy with them, walk with them, help them with their grieving, help them with their process of how they will allow natural death for the baby after the baby is born. in those kinds of circumstances. And that goes back to the ERDs of the sanctity of life, the reverence for life, the not doing terminations, the caring for the mom and the baby all the way through.
What's not always so well understood is the Church's prohibition against contraception and sterilization. We can see that in contraception or in surgical sterilization that we're separating the procreative, we're suppressing or putting a barrier or surgical exclusion to the ability to procreate while having the unitive present. And then if we move into the assisted reproductive technologies, the goal is clearly to procreate, but it's not done within the unitive, within the couple.
And there's some times that the ERDs encourage us to step back, to counsel, to listen. Perhaps we can't fix it, we can't fix that infertility, but we can counsel the patient, we can talk about other options. Those kinds of differences in our care that are very compassionate and really very appropriate to excellent patient care. But they're, and very much in keeping with the values of a physician that we sometimes forget as we get very busy and want to just make it better and then move on to the next patient.
Sometimes difficult cases arise in which life-saving treatment of a mother may harm her unborn child. The directives offer guidance for these cases by employing the ethics principle of double effect.
It's called the principle of double effect because, in fact, it recognizes that a specific action may bring about two effects. One effect, which is the good effect, is the one that's intended by the person acting. And the second effect, while it might be foreseen or even tolerated, is not the intended action, but one that the person acting or the moral agent recognizes in fact will happen. There are traditionally 4 conditions to fulfill the application of the principle of double effect. First, the action itself must not be morally or intrinsically evil. It must be good, or at least some persons would define it as being neutral. Second, the evil effect must not be the means to bring about the good effect, because we all understand or remember the moral axiom that the end cannot justify the means. Thirdly, the evil act may not be the one that is intended, although it may in fact be tolerated. So the intention of the person acting is important. And lastly, there must be a proportionate reason or a proportionate good to cause one to act in such a way. One of the most classic examples was that of ectopic pregnancy. If a woman comes into an emergency room and is in really severe pain, and it clearly seems that she may be about to rupture, or her fallopian tube may be about to rupture. There's a recognition first that she is pregnant and that the zygote in the fallopian tube cannot continue to live outside of the mother's body. But there's also a recognition that unless the physicians intervene, neither the mother nor the zygote will continue to live at all. So there's a need to intervene surgically with the removal of the fallopian tube. The good effect in that case is saving the life of the mother. The evil effect, which is foreseen but not intended, is the intervention that will end the life of that zygote.
With respect to beginning of life issues, physicians often find themselves caught between the proverbial rock and a hard place, the difference between could versus should.
For a doctor to say, what am I going to do here? And to know that he or she has enormous possibilities because of all the things medical science tells us we're able to do. The ethical and religious directives help answer that second question. What should I do? The difference between what I can do and what I ought to do.
New interventions in obstetrics, such as doing fetal surgery, or potentially being able to do an intervention which could correct genetic defects, offers a rich environment for which the clinician can sort out the appropriate treatment and application of these new procedures.
What we can't do is pursue prenatal diagnosis with the intention that the only option is to abort. And so for conditions for which there is no treatment, for having this knowledge would really not benefit the patient and her baby at delivery, and that would not be something that's permissible.
The inherent dignity of each human life from its conception until death requires a profound respect that characterizes the care described in the directives.
There's something very holy going on here in this maternal child health part of the hospital. I think there's something holy going on in everything we do, but that new life and so forth is really a very blessed time.
Human life is a gift, and we're the stewards of that gift, not the owners of it. And I think that is a primary principle that Catholic healthcare recognizes. We're custodians. We're the stewards of this incredibly wondrous gift.
The reverence for life, that sort of intangible, is something that patients feel. When they do come here, they'll talk about it. There's more a feeling of compassion and true caring. And it percolates through the entire hospital.
As we close our discussion of Part 4, there are a couple of ideas in the introduction that I think are critical and that I wish to highlight. As with other sections of the directives, this one is framed in terms of respect for human dignity. Respect for human dignity leads to a profound respect for the sanctity of human life and the sacredness of marriage and of the Marriage Act. With regard to the Marriage Act, it is important to note that the Church believes that God created this act to be both unitive and procreative, and that the two purposes ought not to be separated. When they are, as in contraception and sterilization, the dignity of the Marriage Act and God's will are deemed to be violated. This leads the Church to say that contraception and direct sterilization are morally wrong. In a similar vein, the Church believes that God has willed that all human life should originate from this Marriage Act. When this does not occur, as in many reproductive technologies, human dignity is also deemed to be violated. For this reason, the Church forbids artificial insemination, whether by the husband or a donor, as well as in vitro fertilization. The directives do encourage Catholic health care to provide prenatal, obstetric, and postnatal services for mothers and their children, to offer compassionate care to women who have suffered from the trauma of abortion, and permit genetic counseling and prenatal diagnosis. Directives 47, 48, and 49 provide guidance for dealing with difficult pregnancies. Interpreting and applying these latter directives is not always easy and may require input from an ethicist or a theologian.